let me take this opportunity to welcome our branch president who is presiding this meeting, Dr. Rakesh, to this meeting. I extend my welcome to the state president, Dr. Vijay Kumar sir, and to the state secretary, Johnny Sebastian sir, who is attending this meeting. Thank you, sir. Thank you for attending most of our meetings and giving such a good encouragement to the IAP Thrissur activities. Again, I welcome Dr. VKP madam, VK Parvati madam, who is inaugurating today's session, and Anantha Keshavan sir, who is the South Zone Vice President 2020 and member of ACVIP. I welcome him to today's meeting, and he'll be chairing today's session. And the main person for today's event is Dr. Tanu Singhal, who is the speaker today. She's a consultant at Dhirubhai Ambani Hospital, Mumbai, and she'll be giving a talk, 13th talk in the series. And again, I welcome all the senior pediatricians, including Purushothaman sir and all other senior pediatricians and their colleagues and friends to this wonderful academic session. Thank you. Over to you, sir.
I invite Dr. Rakesh to give his presidential address. Over to Rakesh. Rakesh, unmute.
Good evening, sir. Audible? Yes.
Yeah.
Yeah. Good evening. Thank you, Anantha Keshavan. Also, warm welcome to our state president, state IAP president, Dr. Vijay Kumar M. sir, Dr. Johnny Sebastian, speaker of the day, Dr. Tanu Singhal from Mumbai. And there's a small correction. Dr. Vijay Kumar M. sir will be giving the inaugural talk. And all the senior members, colleagues, seniors, welcome to God's own country. Welcome to Thrissur. And this has been an excellent talk series, and we have been focusing on non-infectious diseases, the health issues, the obesity problems, and all that. But now the schools have reopened, and it is time we also get back to the routines of the pediatrics, right from the infectious disease. And we have the right person here, Dr. Tanu Singhal, to give us to have a very good case discussion on the infectious disease case scenarios. Thank you, sir. Over to Anantha Keshavan, sir.
Now I invite our state president, Dr. Vijay Kumar, to give inaugural address, a brief address.
Respected Dr. Anantha Keshavan, my best friend, my classmate, CIAP Vice President, past Vice President, and ACVIP member, and the man behind this Thrissur talk series. And Dr. Johnny Sebastian, the respected State Secretary of IAP Kerala, my best friend, and the person behind all these activities of IAP 2021-2022. The speaker, Dr. Tanu Singhal, the president of IAP Thrissur, Dr. Rakesh, Secretary Dr. Pavan, Treasurer Dr. Itub sir, Dr. Srijit, Parvati madam, Purushothaman sir, and my seniors and my best friends. And hearty congratulations for IAP Thrissur for conducting the most sought after virtual program of this year and past year of IAP Kerala, Thrissur Talk Series, mainly on infection and immunization. This is the 13th edition. I think I have heard most of the past editions of this Thrissur Talk Series, and I am very glad to be a listener of this program and part of this program. I wish you all the best for this program. Jai Hind and JIAP. Thank you all.
Thank you, Dr. Vijay Kumar. Now I invited Dr. VK Parvati madam to say a few words. VK Parvati was head of the Department of Medical College, past head of the Department of Medical College Thrissur, and the past state president of IAP. Welcome, madam. Parvati madam. Unmute, madam. Unmute.
Good evening to one and all, and it is a great pleasure to be here to attend this 13th talk series of infection immunization of Thrissur. And I congratulate Dr. Anantha Keshavan and the team behind, including the past secretary, president, and the present president and secretary, and for this wonderful series. And it is
Unmute, madam.
It is indeed a pleasure to listen to Tanu Singhal, an international figure in this talk. Thank you once again. Thank you all.
Go to Dr. Johnny Sebastian to say a few words to felicitate. Johnny Sebastian.
A very good evening to all. Respected chair and my dear friend, Dr. Rakesh, my guide and state president, Vijay Kumar sir, Anandakeshwaran sir, ACVIP member and past national vice president, South Zone, the vibrant secretary of IAP Thrissur, Dr. Pavan, Dr. Srijit, the past secretary, seniors, Parvati madam, past state IAP president, Purushottam sir, seniors and other colleagues who have joined us today on this platform. I'm extremely happy to attend the prestigious Thrissur talk series on immunization and infections. And today we have none other than Dr. Tanu Singhal, a faculty and a true academician and a speaker who is sought out everywhere at the national level as well as the international level. So I wish this webinar all the very best and all the participants a great learning experience. Thank you. Jai Hind, JIAP.
So thank you, Dr. Johnny. Now we'll go to scientific program. Infectious disease. I think it is again, as Rakesh mentioned, an important program. And also here it is, we are conducting every last Thursday. We are conducting talk on infection immunization. And as we know, the treatment of infectious disease varying from person to person and individual, because usage of antibiotics, which antibiotics, everything is a dilemma. And also treatment of a different case scenarios. I think that's very important rather than any theory discussion. So I think Tanu Singhal madam calculated a series of cases, and I think you can expect a very good scientific feast in next 40-45 minutes. Tanu Singhal is a very famous international speaker. She completed her MD PDADs from All India Institute of New Delhi and a MSc Infectious Disease from London School of Hygiene and Tropical Medicine. And she is attached to already mentioned Dhirubhai Ambani Hospital in Mumbai. And she was also executive board member of Fungal Infection Study Forum and also RNTCP National Expert Group. And she got a prestigious IC Verma Excellence Award in 2020. And also she got a more than 85 publications in various index journals. Really, we are very, very lucky to have an international speaker with us to discuss the various aspects of infectious disease. Once again, welcome, madam. Over to you to deliver your talk, madam.
Thank you. First of all, I'd like to thank you, Dr. Anand, for inviting me for this session. And I hope that the cases are interesting and you are able to get some learning points. So with that, I'm just trying to share my screen. Shit. Sorry. Sorry, 1 minute.
First slide, madam.
Yeah, just 1 second.
Yeah. No problem.
Yeah, can you see my screen now?
Yeah.
Yes.
Yes.
Yeah. So, so basically, I will discuss some unusual cases which may not commonly be seen in practice. I mean, because otherwise, then they wouldn't be interesting. And basically, there is some common thread in the cases. And finally, I think the message from the cases will be how not the diagnosis, but how we arrived at a diagnosis, and how in some patients it took a long time to reach a diagnosis, and in some patients the management issues were challenging. So coming to the first case, this is patient, who was a 3-month-old female baby, and she was diagnosed as congenital heart disease in the neonatal period, and she presented at age 3 months with failure to thrive and fast breathing. And our hospital is a center for excellence for pediatric cardiac surgery, where we do almost 1,000 surgeries a year. So a lot of complex congenital heart disease is referred to us. So she presented to the cardiac services, and when her weight was 4 kilos, she had low saturations, and she had a murmur on cardiac examination, but there was no organomegaly. So at that time, she underwent an echo and CT PA, and it was diagnosed as type 1 truncus arteriosus. So basically, type 1 truncus arteriosus is a condition where you have a common origin of the great vessels, which then go and divide into the pulmonary artery and into the arch of the aorta, and you basically have mixed blood, which is circulating. So this was type 1 truncus, and she underwent some basic investigations, which were really seeming unremarkable at that point in time. And I would urge the people who are in the audience to write what they are thinking about as the case progresses. What are their thoughts about what is happening to the child? So basically, she was operated and the truncus correction was done, and it was quite an extensive surgery, and bovine pericardium patch was put. And whenever we put a bovine pericardium patch, we also send it for culture at the same time, and that culture was negative. Now, in the immediate post-operative period, she had developed fever with leukocytosis and high CRP, but which settled, and a blood culture was sent at that time, and the blood culture was negative. Now, 15 days after surgery, she developed fever which had no focus. So, in the post-op period, she was investigated, and the counts were more or less the same. There was monocytosis on the peripheral smear. The CRP was mildly elevated. The blood culture was sterile. And the echo showed no vegetation. At that time, of course, an HIV test was done even before surgery, and it was negative. So, at that time, the thought in the mind of the operating team was that maybe she's got some bacterial infection after this extensive surgery. They started her on empiric antibiotics, but fever persisted. Now, because there was persistent fever, which was like a PUO, where cultures were sterile, echo was negative, they did a CT chest and abdomen, and it showed mild hepatosplenomegaly. Rest of it was reported as normal, and the fever gradually came down. But this patient had stayed in hospital for 1 month, and at the time of discharge, the weight was 4 kg, but by now her saturation had normalized. So I would like the people in the audience to try and think what would go through there, or what would their possibility for such a prolonged fever be. Now, moving ahead, the 6 weeks after discharge and almost 10 weeks from surgery, because she had remained for 1 month in the hospital, and then 6 weeks later she came. And what was found was that, she was having cough and poor feeding, and her weight was still 4 kg. So she had not put on any weight after discharge, and the saturations had actually come down to 82%. And this time a CTPA was done again, which showed severe stenosis of the left pulmonary artery. So probably that was the reason for the, can you hear me?
Thank you, madam.
Yeah. So that was the reason for her desaturation. So she was advised admission. But the parents were poor, and they were coming from a remote area. They did not immediately admit the child, but they admitted her after 2 weeks. And by this time, she was febrile, and she was also tachypneic. So whatever disease she had was kind of persisting, because we really don't have any satisfactory explanation of what was the cause of fever even at that time, for almost after surgery. Now, she was admitted again, and she was investigated. Now, if you look carefully, her hemoglobin had dropped. She had a normal white cell count with 83% polys, 10% lymphocytes. The peripheral smear was normocytic, normochromic. There were some target cells in the peripheral smear and some nucleated RBCs. The platelets were 1,87,000. CRP was 83 milligrams per liter, so it was high. ESR was high. Albumin was a little low. If you look at liver enzymes, you find that there was some derangement of liver enzymes with elevation of OT and also GGT and SAP, suggesting, what you see like in a granulomatous hepatitis. Blood cultures, 3 sets were sent, and echo showed no vegetations. So again, this was a situation where she had pyrexia, she had cough, but a cause couldn't be found. So at that time, as a part of workup of PO, CT was done. And if you look at the CT, it basically showed that there was some infiltrates in the lung. And apart from that, what was characteristic was that in the spleen and in the liver, she had hypodense lesions. So basically what looked like abscesses. So what would you think of? In this patient, now you obviously start thinking of disseminated TB in view of the splenic and hepatic lesions, but the parents, there was no history of TB in the family. We also thought of endocarditis, but the blood cultures were repeatedly negative. But anyway, because TB had to be ruled out, we sent a gastric lavage for AFB, and that showed no AFB on smear, but the expert was positive and there was no rifampicin resistance. So the patient was started on 4-drug AKT with HRZE, and the fever, however, continued, and the child developed severe diarrhea. And at that time, we found that her white cell count had gone up, platelets had dropped, and she had actually developed another infection, a carbapenem-resistant Klebsiella, and then she also grew salmonella in the blood, which is like a non-typhoidal salmonella. So again, on top of the TB, now she had actually 2 bacterial infections. So treatment was initiated with colistin and meropenem, but the patient's fever and diarrhea kind of persisted. So isn't it quite odd that a patient comes with truncus surgery and she gets operated for that, and then she develops fever, and then that fever continues and she gets diagnosed with tuberculosis, and now she also develops other infections. So is there something else happening? Because at that time, the intensivist of the cardiac ICU said that, look, something is not right with this child. Why is she behaving like this? This is not something we operate cases of congenital heart disease all the while, and we don't see children having such a bad course. Our center hardly sees any cases of post-op endocarditis, and her blood cultures are sterile. So these are the investigations. If you look at them serially from day 0 to day 24, you find that her hemoglobin is dropping. Then you see that their white cells were dropping. But more important than the white cells, you look at the absolute lymphocyte count. The absolute lymphocyte count was going down. Also, platelets were kind of going down. And CRP was actually quite high, and it remained persistently high. So that is odd. You could say that the absolute lymphocyte was going down because she had a bacterial infection and now she had more polymorphs. But then we should also think of something else. So this is in summary what was happening to her hematological investigations. So what are your thoughts at this point in time? In summary, a 5-month-old with complex congenital heart disease with fever and failure to thrive, disseminated mycobacterial infection, very low absolute lymphocyte count, bicytopenia, high CRP and ferritin, culture-proven bacterial sepsis, and possible fungal sepsis, because her BTG was also high. So could this be a severe immunodeficiency disorder? She was HIV negative, but then we did a lymphocyte subset analysis from Vardia, and what we found was that if you look at the lymphocyte count is percentage is 7%, 314, whereas the normal lymphocyte count at this age is between 3,400 to 9,000. And if you look that though there is a decline in both B lymphocytes and T lymphocytes, it's the T lymphocytes which are very low, just 2 T lymphocytes in this patient. And also the NK cell count was normal. So again, we thought that whether this is B positive SCID, because the first surgery absolute lymphocyte count was about 2,000. And then we reviewed the CT and there was absent thymus. There was no BCG scar. But then why should she have a truncus? So which is the kind of immunodeficiency disorder where you get congenital heart disease and you may get a severe T-cell mediated immunodeficiency, and that is DGeorge syndrome, because it is a severe cell mediated immunodeficiency, and the characteristic congenital heart disease which is associated with DGeorge is conotruncal CHD. And when we look back at her reports, we found that she had one reading of hypocalcemia in the past. Now, so it did seem obvious that this patient had an immunodeficiency, which was a T-cell mediated immunodeficiency. But the next question was that if we needed to confirm the immunodeficiency, we would need a whole exome sequencing or a FISH for DGeorge. But then the other point which we couldn't understand was, why did she have this disseminated mycobacterial infection? Because there was no contact history and the child is just 5 months old and the parents' chest X-ray was normal. So the next point which we thought about was that could this be disseminated BCG? Because we know that if there is a patient who has a severe combined immunodeficiency and gets BCG at birth, they can have a complication. And we must understand that the expert cannot distinguish between MTB and BCG. So the gene expert will be positive with both MTB and BCG, and we need a separate kind of line probe assay to on the culture or to find out whether it is BCG or whether it is MTB. Or we can do pyrazinamide susceptibility, because BCG is pyrazinamide resistant. Unfortunately, the baby was taken DAMA by the parents before we could figure out what was the exact immunodeficiency that the child had, and before we could confirm BCG. So what are the various kinds of learning points in this patient? The first thing is that when you have a congenital heart disease, we must try and identify the syndrome, because what happens is that the patient goes to a cardiac service, which are anyway very busy, and they see the congenital heart disease, but they don't look at the child in whole. So especially for patients who come with a complex CHD like a truncus. Also, maybe one should have thought of DGeorge in a patient who comes with a conotruncal abnormality. The child should have been investigated for DGeorge, and one should think of DGeorge in the following settings, especially if you have a dysmorphic child or a cleft palate with a CHD or an immunodeficiency or a hypocalcemia or absent thymus. Now, the child had 2 or 3 CT scans which were done with us, but in none of the CT scans, the thymus was commented upon, because nobody looks at the thymus. Whereas if you have an infant and there is an absent thymus, that itself should alert that the child could be having an immunodeficiency disorder. The third thing is that if you have any child with DGeorge, you should evaluate carefully for immunodeficiency. And the fourth important learning point is that in babies who come with severe infections in infancy, always keep primary immunodeficiency disorder as a possibility. Therefore, look at the CBC and ALC carefully. Now, even in this patient, we had a prior ALC. If you look at this first test which was done, when she came, there was a time when her count was done, which was 10,000. At this point in time, the child was not having any infection and her lymphocyte percentage was 20%. So that means her ALC was 2,000, which is actually low, because at this age, the ALC should be more than 4,500. So that maybe if that was seen, and the fact that she had a heart disease was seen, one may have acted earlier. The ALC can be normal, however, in patients with severe combined immunodeficiency due to circulating maternal lymphocytes. And also ALC can be falsely low during an infection. So these are the important caveats while interpreting the absolute lymphocyte count. And the final learning point is that in a child with disseminated TB or an infant with disseminated TB, also keep disseminated BCG as a possibility, especially if there is no clear contact history. So you have an infant who comes with fever, hepatosplenomegaly, miliary mottling, and we do expert, it's positive, we always take it as TB. But maybe some of these patients could be BCG, because even our expert cannot differentiate, even your culture will not differentiate between MTB and BCG, and we may be treating these patients as TB, whereas they have disseminated BCG. So that's another point which we must keep in mind. Now moving to the second case. Now, this is again an interesting patient. Actually, he came to us about 8 years ago, but we have started seeing more and more such cases since that time. And therefore, I thought it would be interesting to share this case with you. This is a 2-year-old boy from Kolkata, actually. He had developed this right cervical adenopathy for 2 weeks, of 2 weeks duration. And if you look at this, the child had no systemic symptoms. The lymph node underwent rapid suppuration. They did a MAN2, which was negative. And when an aspiration was done, it was AFB positive, the pus. But the expert was negative. And this was done in a local lab in Kolkata. And it was an affluent family, and there was no contact with TB at this age in this patient. So at that time, the patient had come to us in Mumbai when anti-TB treatment was already started. Now, when he came to us, we thought that whether this is a non-tuberculous mycobacterial infection, because the expert was negative, but the AFB was positive. But NTM is supposed to be very rare in India in a ratio of about 9:1. 9 out of 10 cases of mycobacterial adenitis will be TB, and only 1 will be NTM. So, and sometimes the expert can be false negative. So this patient was started on anti-TB drugs, and at 6 weeks, the culture was negative, which is odd, because if the smear is 4+ or AFB positive, the culture should go, but the cultures came negative. But by this time, the child had a good clinical response. So the treatment was continued, and pyrazinamide was stopped at 2 months. Now, then this child was in Kolkata, and the child continued to have increase and decrease in the size of the nodes, but there was no systemic signs. There was fair weight gain. So the parents continued the anti-TB drugs for 15 months, because what would happen is at 6 months, 9 months, the node was still present. So it was, treatment would be extended. And then after 15 months, they decided that enough is enough, and they stopped the anti-TB treatment. Now, 3 months after stopping therapy, the child presented to our hospital with a sudden increase in the lymph node size with upper airway obstruction and obstructive sleep apnea. So he couldn't sleep properly. And when we actually did a CT scan, we found that the child had significant cervical adenopathy with a parapharyngeal abscess. So that time we had to take up the child for an emergency abscess drainage. And when we did biopsy, we found that it was granulomatous inflammation, but again, AFB were absent and the expert was negative. So at that time, we thought that this patient has some kind of mycobacterial disease, which is not resolving. So we screened for immunodeficiency, especially chronic granulomatous disease and Mendelian susceptibility to mycobacterial disease. It was negative. And at that point, we thought that now we should be thinking of non-tuberculous mycobacteria. And we gave the child a combination of clarithromycin-based therapy, and to which the child actually responded, and the child did well. And over the past many years, the child has never had a relapse. So this was basically a case of cervical adenopathy due to non-tuberculous mycobacteria, where the diagnosis was substantially delayed. Now, because this was early on, and now we have seen many such cases, and I'll discuss this problem further. So these non-tuberculous mycobacteria are TB-like bacteria, but they come from the environment. More than 100 species have been identified, and the common ones which we have heard about are like Mycobacterium avium intracellular, Mycobacterium kansai, Mycobacterium scrofulosium, Mycobacterium kiloni, etc. And the clinical syndromes associated with non-tuberculous mycobacteria in children are cervical adenitis, that's the commonest syndrome, pulmonary disease, especially in children with cystic fibrosis, disseminated disease in HIV patients, and nosocomial skin and soft tissue infections following surgery, especially laparoscopic surgery, because there the laparoscope is often not sterilized, and then you get these skin and soft tissue infections. So the diagnosis is by smear, which will show AFB, but the acid-fast bacilli in NTM are usually short and broad, and not like the long and thin, which is seen in TB, and also culture. Because remember, like I showed you the previous case, in BCG, your CB-NAT will be positive. But in atypical mycobacteria or non-tuberculous mycobacteria, your CB-NAT will be negative, and the culture will clearly tell you that this is non-tuberculous mycobacteria because the MPT64 will be negative. So while there is difficulty in distinguishing BCG from MTB, there is really not much difficulty in distinguishing NTM from MTB. Also, another problem with NTM is that the culture isolation rate is very low. This is because the NTM have a lot of fastidious growth requirements, and you have to incubate in carbon dioxide, you have to incubate at lower temperatures, you have to add sheep's blood, etc. So that is why you can't commonly grow them on culture. And the treatment of NTM disease depends on the syndrome and species, but can include just observation or medical and surgical therapy. Now, when we come to NTM lymphadenitis, which is what this patient had, it is basically most common causes are MAC, Mycobacterium scrofulosium, Mycobacterium haemophilium, malmoense, etc. And it is most common in children between the ages of 2 to 5 years, because these children have a tendency to put everything in their mouth, and these mycobacteria are actually present on the in the environment. So they put a pencil, they put the toys, and that is how it enters, and that is why you get cervical adenitis. Usually the swelling is unilateral with no systemic symptoms, so there won't be any fever, etc. And sometimes you will find that it will rapidly increase in size, it will form an abscess, and the tuberculin test may either be negative or positive. The chest X-ray is normal, and while your histopath will show granulomas, your smear may show AFB, but the CB-NAT will be negative, and the culture will be is mostly negative. So the treatment of choice is actually surgical excision, but it is sometimes difficult because of proximity to the facial nerve, which can cause facial palsy. So chemotherapy is not well standardized, but basically is recommended to use either rifampicin or rifabutin with clarithromycin, ethambutol, and quinolones. So remember, for most non-tuberculous mycobacteria, clarithromycin is the preferred drug, but along with that drug, you have to use other drugs as well. Now, NTM lymphadenitis in India is less common than MTB, but unlike developed countries, because it is believed that the BCG may give protection. However, in one series of which was reported, 13.5% of culture positive mycobacterial adenitis was due to NTM. So remember, you must think of NTM in certain situations when a child comes to you with cervical adenopathy with no systemic symptoms, where you have granulomas, but your expert is negative and your smear is positive. So that is the situation where you must think of NTM. Now, how are you going to manage these patients? Because will you start standard anti-TB treatment, because you know that many times your expert can be negative in a lymph node, and NTB is more common than NTM. Are you going to wait for cultures? But as I said, your NTM culture positivity is low. Will you start NTM therapy? Because in NTM therapy, if you use drugs like rifampicin, ethambutol, clarithromycin, you are like partly treating MTB also. So what we are doing at our center is that if you have a case like this, where you think it is NTM, but you're not sure, we give treatment for both MTB and NTM. So we give the standard first line AKT and we add clarithromycin to it, and we give it for 6 months. And we've had about 7 or 8 such children who have actually done well without the need for surgical excision. Now, coming to the last case. This is actually a case where the diagnosis was not so much difficult, but the treatment was difficult. This is a 13-year-old girl who came to us with severe abdominal pain on the right side for 2 days with repeated vomiting, but no fever. On leading questioning, she told us that she had lost 7 kg weight in the past 2 months. And there was a history of Kikuchi disease 2 years back. At that time, it had resolved with just symptomatic therapy, and ANA was negative. I think it was just borderline positive. And when she came to me in the OPD, basically she was afebrile, she had tachycardia, she had multiple neck nodes, and she had mild tenderness in the right iliac fossa. And she had already come with some investigations done outside, which showed that she had normal counts, she had a mildly elevated CRP, ketones were present, and an ultrasound abdomen showed hypoechoic nodes in the right iliac fossa, but the appendix was not seen. So actually, when she came to me, I thought that maybe this is acute appendicitis. And because she already had a non-conclusive ultrasound, I asked for a CT abdomen with contrast. And if you look at the CT abdomen with contrast, you'll be surprised to see that she basically has a left kidney, which is normal. But if you look at the right kidney, it is showing infarcts. And if you look at the renal arteries, this is the left renal artery. But if you look at the right renal artery, it is very narrow. So basically, she has infarcted her right kidney. And when we did a CT of the chest, we found that she had multiple necrotic lymph nodes in the mediastinum. So at that point in time, we considered the possibility of vasculitis, maybe Takayasu's, because she had features of tuberculosis with the lymph nodes, and she also had vasculitis. So we did a core biopsy of the cervical lymph node, which showed necrotizing granulomas with caseous necrosis. And that is not like Kikuchi, because otherwise we would have expected that maybe the nodes are because of Kikuchi. No AFB was seen, and the expert was negative. So at this point in time, we started treatment with steroids and anti-TB drugs. Now, if you look at the differentials in this patient, what are the possibilities? One is that this is Takayasu's, because she has these necrotic lymph nodes and she has vasculitis. The other possibility is that whether she has a polyarthritis nodosa, because she has renal artery involvement, and rapid course. The third possibility is that whether this is Wegener's or granulomatous polyangiitis, because she has necrosis in the granulomas, but in Wegener's you will see vasculitis also, which was not seen. And the other possibility is whether she had lupus with antiphospholipid syndrome, because Kikuchi can be associated with lupus. Lupus can cause vasculitis, especially if there is APLA positive. So we investigated her, and we found that ANA was weakly positive, C3 was normal, ANCA, which you do for GP for Wegener's, was negative, anticardiolipid antibodies was negative, and she also had involvement of the renal vessels, but she had aortic valve involvement also, which is uncommon in polyarthritis nodosa, because there you have mainly a medium vessel vasculitis, not a large vessel. So finally, we diagnosed it as aortoarthritis with TB. We knew this was not PAN because there was aortic valve involvement. We knew this is not Wegener's because ANCA was negative, and we knew this was not lupus because ANA was also not clearly positive, C3 was normal, and APLA were negative. So finally, we diagnosed it as aortoarthritis with TB. And actually, she had a very stormy course. So we started steroids and anti-TB treatment, but her blood pressures just shot up because she had renal artery stenosis. She had stenosis of both the renal arteries, right more than left. Because here also, if you see the left renal artery, also there is stenosis. So she had hypertension, for which she needed to go to the ICU. And then suddenly she developed severe abdominal pain now on the left side. With anuria and rising creatinine. Her creatinine went up to 3.5. And when we did a urgent angiogram, we found that the left renal artery was also closing. So then we did an emergency renal artery balloon angioplasty to open up the left renal artery, and we started her on cyclophosphamide and pulse methylpred for her vasculitis. And we started her on dual antiplatelets, and she gradually recovered. Her urine output recovered. Her creatinine, which had gone to more than 3, started coming down. But despite giving her cyclophosphamide and high-dose steroids, she continued to have high inflammatory markers. And her repeat MR aortogram, which was done 10 weeks from the onset of illness, found that she had new involvement now. If you look at the aortogram, you can see that this is the celiac axis, and there is narrowing of the here. Then you can see this involvement of the aorta. Then if you look at the if you look at the arch of the aorta and you look at the subclavian, the left subclavian, you can see that there is narrowing here, and you can already see that there is a narrowing in the renal arteries as well. So this is again the infarcted right kidney and the perfused left kidney. So we actually had to start her on tocilizumab, and we offered a renal auto transplant, because you know what will happen is if the left renal artery closes, then she will develop autonephrectomy. So in such patients, after the disease has stabilized, what the surgeons do is that they resect the kidney and anastomose it to a healthy artery. She actually had another episode of press, and but then she got better after tocilizumab, and which is now planned for her. So basically, this was a case of TB-associated aortoarthritis, which was very difficult to manage. So you can see what is the common thread in all the three cases, that somehow these cases are related to mycobacteria. The first case was of a severe immunodeficiency disorder, which had probably disseminated BCG infection. The second case was a case of non-tuberculous mycobacterial cervical adenitis. And in this third case, the pathology was not directly due to TB, but because of the aortoarthritis, which resulted from TB. So, and therefore these cases also illustrate difficulties in diagnosis and management. Like in the first case, the diagnosis was a problem, and by the time it was made, it was too late, because we diagnosed the severe combined immunodeficiency quite late. By that time, we couldn't do a bone marrow transplant for the patient. In the second case, both the diagnosis and treatment was the issue, because it took almost 18 months for us to actually realize that this is not a case of MTB, but this is a case of NTM, because it was probably one of the first such cases that we had seen. And the third case, though the diagnosis was straightforward, management was complex and it needed interdisciplinary care. So we had to take opinion from the rheumatologist, and we also had to take help from the interventional radiologists who were able to do an emergency renal balloon angioplasty. Otherwise she would have lost both her kidneys and she would have been dialysis dependent forever. I think with that, I would like to, stop sharing my screen and take questions from the audience.
So three important varieties of cases, dietary or indirectly related to tuberculosis, and they are different course and how it was investigated. It was a nice journey to go through all the history and investigation. Even though tuberculosis is not very common in Kerala, we are in the phase of eliminating latent tuberculosis nowadays. And first case, is there any dysmorphology for DiGeorge syndrome? That CHD with the dysmorphology without dysmorphology? You may get it, but there's no dysmorphism mentioned. And also BCG as such, is it maybe a congenital tuberculosis? Any evidence of congenital tuberculosis, anything like that? First case, madam.
It was not congenital tuberculosis, because if you see, the parents were normal, and when the child had initially come for that surgery, she had undergone a CT done at that time, and she didn't have any evidence of TB at that time. So it is definitely not congenital TB. About dysmorphology, she didn't have anything major, but she was a very small child. So it was not sometimes it's very difficult to pick up the features at that age, but she didn't have any obvious dysmorphism, which we often see in DiGeorge. She didn't have that. So that is the reason why we thought that she actually had disseminated BCG, because there was no contact in the family, and she did have a severe cell-mediated immunodeficiency. But in order to prove that it was indeed BCG, we would have had to, do a proper line probe assay on the culture to try and differentiate between BCG and TBC. A similar situation is when children come to you with an abscess in the thigh after DPT, and then you aspirate the abscess and you find that they are AFB. So their expert comes positive. So many times people think that this is TB, but actually it is BCG which has been accidentally given in the thigh. So we've seen many such cases, and that time it is really difficult to differentiate the BCG and TB. But what we do in these children, if there's no evidence of TB elsewhere, we just treat them symptomatically and they all get better.
A second case of NTT, not done a biopsy. If it is very useful if you are done a biopsy, because you are in a FNAC and also done a CBNAT test. But if you are, because we had a couple of cases with a similar cervical lymph node turned to be NHL. Here are two cases of non-Hodgkin's lymphoma, one case of Burkitt's lymphoma. So, madam, we have done a biopsy.
Biopsy was done. Biopsy showed granulomas. Biopsy
Biopsy
showed
done.
necrotizing granulomas. In the first time, biopsy was not done because it was all pus. So they had aspirated the pus. And that aspirate of the pus showed AFB, but expert was negative. So definitely that cannot be NHL or a Hodgkin's lymphoma. And also the course was very protracted. It was about 18 months. And when the patient came back again the second time, that time also we did a biopsy and we did an excision biopsy and it showed that it was granulomas only. So I agree. So that dilemma is always there. So if you have a patient where you've done an FNAC for a cervical lymph node and that FNAC doesn't show necrotizing granulomas and is expert negative, you must do a core biopsy or an excision biopsy because you may be missing a Hodgkin's or an NHL in that situation.
Third case, again, we used to say that the association between tuberculosis and the Takeda disease. We also used to prescribe like that. But any further progression on follow-up because first mentioned about renal artery, then mentioned about the subclavian artery. Is any further progression of this case?
No.
Any other artery involved?
No, now it is, see, she's still under treatment. So we don't know. She's still under treatment. But what we can say is that clinically, she's much better after the tocilizumab. Because now her, at least her fever has gone, her ESR has come down, her CRP has come down. And somehow we feel that even now people don't really know whether there is really an association between TB and Takayasu, because Takayasu also happens in countries where the prevalence of TB is less. And this child actually gave us a lot of clues that she does have an autoimmune problem because 2 years ago she had Kikuchi. Okay, so that also indicates that she has an autoimmune problem. So maybe this time the vasculitis that she has is due to autoimmune reasons and the TB may just be incidental. Because many times if you do CT scans, etc. for patients, you might find these necrotic lymph nodes. But we are not sure whether these are really associated with the Takayasu's or whether she actually has some other autoimmune vasculitis which is causing it.
Any other question from audience? Actually, we expected a few more cases, madam. Okay.
Okay.
Any other cases?
Yeah, so if you want, I have some other cases. If you wish, I can present some more, but I don't know. Any questions?
What's also, sir? One question, what are DDs for granulomatous lymphadenitis? There is one question, madam.
So granulomatous adenitis can have a broad DD. It can have TB, NTM, then it can be sarcoid. Then sometimes some fungal infections can also come, tularemia. So there can be a broad differential, but in children, most of it is actually tuberculosis. Yeah. Sarcoid and all are, you should suspect, especially in older people, adults, where you may have non-necrotizing granulomas. And of course, another differential is Wegener's. Wegener's can also have granulomatous inflammation on the lymph node.
Any other? Parvati madam? Parvati madam?
Yes. Really interesting cases. And regarding this arthritis, how often you come across such cases?
Are you talking about systemic onset JIA?
The third case.
No, vasculitis. No, it's very rare, very rare. It's a rare kind of case. Don't see it commonly. I've just tried to show you a case where, there was a link with TB and how difficult it was to manage, such a case of vasculitis, because you think that vasculitis will respond to steroids, but in this case, even steroids didn't work, cyclophosphamide didn't work, and then we had to use tocilizumab. And it was like really a organ-threatening vasculitis because she could have lost both her kidneys. And of course, she had very severe hypertension because of that. But we are seeing a lot of pediatric rheumatology, often as a mimic of infections. That is quite common that, you see lupus, you see Kikuchi, and you see SOGI. In
Very
fact,
interesting cases, all three. But the third one, what was the antituberculous treatment you were giving for that patient?
For isoniazid, rifampicin, ethambutol, and pyrazinamide.
All 4 drugs.
All 4 drugs. And so even it was, expert was negative. See, there is also a possibility whether those lymph nodes were also granulomas were due to some autoimmune process, because expert came negative from the core biopsy. But the problem was that, when we are using such heavy immunosuppression, we have to give her anti-TB drugs, because if she has some TB and we give her steroids, cyclophosphamide and tocilizumab, the disease may flare up. So I agree, we didn't have a microbiologic diagnosis of TB in that patient. We just had a histopathological diagnosis.
In the olden days, we have seen so many cases of tuberculosis, but Takesh's disease was not so common at that time. Now we are detecting tuberculosis less, but we are more detecting Takesh's disease.
What? Kikuchi?
Previously, tuberculosis very common, but at that time, Takesh's arthritis is not very common at that time. Now we are tuberculosis very, very less, but now we are diagnosing more and more cases of Takesh's arthritis.
Okay, yeah. And actually, in Kerala, there must be low TB because maybe of the, overall Kerala is a much better state than the rest of the country in terms of health, education, and poverty, etc. But TB is so rampant in Mumbai. In my day, if I see 10 children, specialized OPD, 5 out of 10 will be TB.
Even now, TB is so rampant in Mumbai.
Yeah. It is very, very rampant. I'm surprised that you all don't see TB in Kerala.
Previously, we used to get cases of tuberculous meningitis, but I think now, I don't know about Thrissur Medical College, any case during past 5 years, I don't think so.
Yeah, we had a case of a TBM. Yeah, we got 2 cases from outside only. Means they are from migrant population. And also, we also got disseminated TB and other TB. 5 cases are there.
Okay, that is very.
And the tuberculosis also 1 case from Palakkad. It was there.
Okay. So that is interesting because, otherwise then you are very different from the rest of India because TB is one of the commonest problems that pediatricians face in the rest of the country. Not TB in all shapes and sizes and at all possible sites.
Any other comments?
Because HIV in
HIV has come down dramatically. Like for you all, TB has come down. For us, even HIV in Mumbai, it was very common 20 years ago. But now, because of the perinatal prevention program, because all mothers are screened and given antiretroviral therapy, the incidence of pediatric HIV has come down dramatically. Hardly see any cases. Most of the cases which are referred to us are for perinatal prophylaxis. So mother is HIV positive. How are you going to manage the infant? That is what we are commonly seeing.
There's one question. How will you manage Kikuchi disease?
How will you
manage Kikuchi's disease?
So Kikuchi is actually a very self-limiting disease. So most of the times we try with naproxen. Naproxen works in many patients, but if they don't show a response to naproxen, steroids and hydroxychloroquine is used. These patients respond very well to steroids. We have to give it for 4 to 6 weeks. And in some patients, we might give hydroxychloroquine for a longer time. But it's a relapsing remitting disease. So the clue to Kikuchi is that you have fever, which is either persistent or recurrent, and you have cervical lymph nodes, which are tender. You have a leukopenia with relative neutropenia, mild thrombocytopenia, and elevation of SGOT, PT, and LDH. That constellation, if you see, in fact, we diagnose about 1 case of Kikuchi per month because it's a common differential now for pyrexia of unknown origin.
Any other question from?
What is the experience regarding primary immunodeficiency disorders? How many are you all seeing or suspecting or diagnosing?
Not very common, madam. We are getting once in a while. We are getting it, and I think Calicut they got so many cases, but in our Thrissur Medical College we are not getting much cases. We are getting one case per 2 months, something like that. Not very common.
Okay. Okay. What about non-tuberculous mycobacteria?
Not, I think I not seen, madam. Non-tuberculous mycobacteria are not seen. Tuberculosis is 5 years back. It's very common nowadays. I already mentioned it's very rare.
So what are the infections that you are seeing mostly over there?
Viral infection is very common. So many viral infection. Then of course we are getting pneumonia due to different bacteria. But again, this is now decreased spectrum after H influenza and pneumococcal vaccine. Now we are getting some other organisms. It's not very common nowadays, but we are getting more case of viral pneumonia.
Okay. Okay.
Even diarrhea is very, very rare. We mentioned about one case of diarrhea also. And lymph node, we had a very surprisingly 2 cases of Burkitt's lymphoma. We also actually they are referred from dental college, and lastly turned to be Burkitt's lymphoma. That is why I asked that question.
Okay.
I think if there's no question, we will wind up. Thank you, Tanu Madam, for the excellent 3 cases, very rare case scenario. And now I invited Dr. Srijit Kumar to propose the official vote of thanks.
Thank you. Thank you, sir, for inviting me. And first of all, I am apologizing for any of the technical glitches that occurred in the initial part of the meeting. So due to security reasons, we had altered our settings. So some people may find it difficult to enter for today's meeting. So I am greatly sorry for that. And but on the whole, I must thank Dr. Tanu Singhal Madam for the excellent presentation, excellent sharing of Madam's vast experience in infectious disease with us, and we are very honored to have you in our 13th episode of Thrissur Talk series. Once again, thank you for joining with us, Madam. And I also thank all the IAP Kerala President, Dr. Vijay Kumar sir, Dr. Johnny Sebastian sir, and IAP Thrissur office bearer, Dr. Rakesh sir, Dr. Pavan, and senior members, Parvati Madam, and all of the delegates who are also joined here for this program. And hope you to see in the next episode of Thrissur Talk series on the last Thursday or in every month. Hope you to see in the next time. Thank you for joining.